All right. If you're ready, Chris, we can get this going. It's 5:30. Thank you guys all for coming. Today, Chris McAndrew, one of our orthopedic trauma surgeons, is going to be talking about pelvic fractures. I have just a couple updates before we get going. First, next month, there will be no conference. Our date falls on Labor Day, and instead of messing with changing the schedule, it just seemed easier to skip it. So no conference in September. And just a heads up for October, this conference is getting bigger, and we're actually going to have our first speaker from outside of WashU. So Sam Galvano, a professor and director of the trauma unit at Shock Trauma in Baltimore, is going to be speaking. That's on October 4th. So I'll be sending out that invite relatively soon, probably first week of September. But just keep that on the schedule, just because it'd be really great to have a good turnout for that. And with that, Chris, if you want to get going, I've started the recording and floor is yours.
All right. Thanks a lot, Justin, for having me. And so my name is Chris McAndrew. I'm one of the orthopedic trauma surgeons here at WashU. I've been here for 11 years, currently the fellowship director. And we're going to talk about pelvic fractures with hemorrhage. And the intent of this truly is to be relatively open. The slides are few and the time to talk is available. And as you guys know, I'm an orthopedic surgeon, so my attention span is short by nature. So feel free to jump in at any point. I'll try to keep an eye on the chat, and Dr. Knittel, if there's anything that comes up, feel free to jump in too. So
will do. I'll look for it as we go along.
All right. Let's see if I can make this happen. In terms of disclosure, I don't have anything related to this topic. I do work with a international group called the AO. I do get paid to travel and teach at courses, and have been on committees with them before, but nothing else currently in terms of funding or research. So the objectives for this talk are just to kind of briefly frame the algorithm for the early treatment of patients that have unstable pelvic injuries, fractures, or dislocations in a patient with hemodynamic instability. Talk a little bit about initial management, and try to get into a little bit more with you guys. This is for my learning too. Updates in terms of specifics. Old papers, speaking of shock trauma from Young and Burgess, are old for a reason. And so there's been a lot of updates since then. Talk a little bit about the rationale and outcomes after kind of, from the orthopedic literature, the treatment of these fractures and dislocations, and then hopefully spark some thought and some open discussion from you guys' experience and pitfalls as well. This is intentionally kind of historic and a little bit of a plug as well. We have a visiting professor coming in October. October 13th is a Wednesday for Grand Rounds in Orthopedics. His name is Chip Rout, and he is really kind of a defining faculty professor for North American kind of musculoskeletal trauma, and specifically focused on the pelvis and acetabulum. And I was lucky enough to be one of his mentees about 12 years ago when he was still in Seattle. He's still working in Houston at the University of Tennessee at Herman Memorial. These papers are, as you can see, almost 25 and a little more than 25 years old. And this was kind of what made Chip really. And that's that he kind of put a lot of thought into this when not too many people were. And was one of my mentors that really did pay attention to the multidisciplinary approach, and had a lot of friends in all the departments, and would tell me things that I couldn't believe he knew as a simple bone surgeon, and things like that. Also things that he saw his comrades do in Seattle that maybe not everybody else was doing. And there were things to potentially take other places outside of orthopedics. I won't bore you with these papers because he kind of summed it up in kind of a 6-statement algorithm, really. And so if you've got a patient with an unstable pelvic ring and they're hemodynamically unstable, he would just try to keep it simple, and when the patient has a pelvic ring injury, especially one that has a volume expanding problem, so an anterior posterior compression type fracture, an open book pelvis, as they say, the treatment starts with reducing that volume, trying to get tamponade with not only closure of the space, but also some stability. Keeping the patient warm is important for their coagulation, and then filling them up. And so we'll talk probably a little bit. I hope you guys are ready to talk about blood resuscitation and all the latest and greatest and what we do here a little bit. It was early, this was the late 80s and early 90s, and they were already doing some pretty advanced stuff with interventional radiology and arterial embolization at the time. And so he was a big proponent of that. Most of their complications were in some pretty gnarly injuries. And so you can imagine with perineal wounds and things like that, he was a big proponent of working with the general surgeons and talking about diversion. And also working with them in a way that, everybody kind of stayed out of each other's way, didn't want to have the stoma coming out in the wrong spot. And then the last thing for his algorithm was what I was there to do a fellowship with, right? We want to fix the bones. There's a fracture. I need to fix it, is the way the old cartoon goes. So that was always last in his kind of approach. And he thought a lot about that too. And we'll get to that as well. So this is a 29-year-old male who was found outside of his car crash, probably not restrained and definitely ejected, and obtunded at the scene. Was somewhere between maybe 7 and 8, but got intubated and arrived here, GCS 3T. And it's just a good way to kind of start. It's a good hook to kind of hopefully draw you guys in. His pelvis doesn't look that bad off when you first look at it, because it looks like things are relatively well together. But if you look at the screen right side, the patient's left side, it looks like his hemipelvis is kind of higher up in the air, right? A little bit further proximal along his spine, and he's got this binder on. So already in this, this is a patient I shared with Dr. Fortuna. Hopefully if he's on, then kudos to him for all the stuff he did in taking care of this guy. But he comes in pretty bad off. He's got a pretty unstable pelvis on the left, fractures in the pubic ramus on the right. And by the time anybody sees him, he's really not communicating. And this is a pretty bad problem. So I think he was either intubated in the field, or he might have been a transfer and was intubated. But by the time he gets here, his systolic is barely holding 100. And every once in a while, when you move him the wrong way, or when they've loosened the binder once to try to get access to things, his systolic's dropping into the 80s pretty quickly. Wrapping them up has already been done. This is kind of the new age. This was a novel idea 20 years ago, but wrapping them up, I think, includes in this patient, if you look back, trying to draw his pelvis back down to the space where it belongs, and that will help contain the volume and also provide a little bit more stability in the sense of trying to get a blood clot to form. So traction put into the skeleton with a thin wire and hung off the end of the bed or the end of the table is a pretty common move. But you guys have seen, certainly here, we use a lot of the kind of prefabricated binders. They've all got some advantages and disadvantages. The application is easier, harder. What it covers up might be a little bit more or a little bit less. But the key is to have something covering, from the iliac crests down to the greater trochanters, because that's your kind of best mechanical advantage to close this volume down. One thing that we try to push a little bit here, because we think it's pretty useful and it's also relatively cheap, and certainly this was Dr. Rout's idea, is the use of just a simple bed sheet from the hospital. And if you do it in a way where it looks like we're going to wrap this patient up quite widely and close off a lot of potential treatment avenues. But if you do this and you kind of keep some modicum of stability spread above the greater above the iliac crests and down below the greater trochanters, what you can do is you can cut holes out of it and still use it. And these are just sketches of his and a case of his where this patient was kept in the sheet through his angiography and embolization. And then on top of that, through his ultimate surgery for fixation of his pelvis. So these kind of windows are useful. And the sheet is obviously a little bit less expensive, so it can be pretty good. Leaving these things on with the clamps near the skin, not a good idea for longer than probably a couple of days for sure, but the goal should be to get it off in 24 hours. So back to this guy, we've kind of succeeded in terms of wrapping him up, but if we go back to the algorithm, we got to keep him warm. And I think that, maybe doesn't get repeated often enough, but is a key. And I think it's not, it seems relatively simple, but with lots of people moving in and out and exposing the patient to do exams, and certainly at our place, lots of sub specialists coming by for another look or another see. Working to keep the patient warm is real work. And I think that's pretty critical. The third step, and hopefully something we can open up to the floor if anybody has any comments, but what are we going to fill them up with, right? And so certainly, if you look back at the Young and Burgess papers from '89 with Dr. Dalal as the lead author, and then Dr. Burgess, the lead author in 1990, all they talked about were how many packed red blood cell units they got. And I can't imagine how some of you guys shudder to think about all the other downstream effects of that. But these patients bleed a lot. And certainly, resuscitation has become advanced. And I think it's open for now or for later, people talking about using whole blood in the right circumstance, but certainly trying to keep ratios of plasma and blood to 1-to-1 or as close as you can while keeping up seems to be beneficial to the patient. So again, back to this guy, we've kind of started that process. He's already gotten a couple of units of red, and we're getting ready to start the massive transfusion protocol. And again, Dr. Fortuna was all over this case. He has a CT scan already, and we get some ideas of how unstable his pelvis really is. Might talk a little bit about this later, but the fact that he's got both a injury in the front part of his sacroiliac joint here on his left side, as well as one in the back of the same joint on the right side. I don't know if my arrows are showing up. They're really relatively elementary, but this is a pretty bad problem. It means he's kind of torn his entire hind quarter away from his spine, and he has the potential for a lot of bleeding. If you pay attention closely to the other side, it looks like the back part of his SI joint is still attached, but even in the front on the other side, it seems like it's gapped open a little bit. So this guy's seen a lot of energy. And it means that a lot of veins have torn, a lot of other soft tissues have torn, and he's definitely got the potential for some real arterial bleeding. And it seemed like he really did. As Dr. Fortuna was kind of working on him, the issue with the blood pressure going low, followed by the finding that he had an intraperitoneal bladder rupture, ended up taking him to the operating room for an exploratory laparotomy and calling me in to help out. And I think that's one of the other keys too, is the ability to communicate across lines for sure, but also communicate quickly and hopefully get a hold of the right people is key. And when the patient's going to the operating room for an exploratory laparotomy, it can be very helpful, even if it's just discussion about future plans for the patient with a pelvic ring injury like this, or any other kind of complex pelvis or acetabulum fracture, to kind of, know what the next steps might be, or certainly help out with intervention. And that's what we're going to kind of get into a little bit. So he has an exploratory laparotomy, and luckily didn't have too much else going on in his abdomen, but had this intraperitoneal bladder rupture, which was repaired. They had done kind of a infra-umbilical dissection as well, and gotten into a space of retius, really not a ton of blood, but still doing pretty poorly in terms of maintaining pressure, and it seemed like he was in shock. And so this patient actually, kind of due to his relatively young age and, seemingly, already out of cardiac reserve and really a lot of unknowns, because he really was non-communicative when he was picked up by EMS, ends up getting Reboa. And I think this case is probably 3 to 4 years old now. And it seems like some of the excitement has gone away. And in kind of reviewing some of these papers, certainly the COT joint statement with emergency physicians and EMS says a lot about how we still don't really know if the results or the survival rates are improved over other well-done approaches in terms of hemorrhage control, whether it be pelvic packing or strictly angioembolization and early fixation, these kind of things. And there are some potential problems, and there's a kind of paper ahead of print out of shock trauma with certainly these are the worst of the worst if you've got a mortality rate in the hospital of almost 50%. But for those that survive, there's a pretty high complication rate, including kind of reperfusion compartment syndrome and fasciotomies, some amputations, and a lot of deep infections. So I think one of the keys when thinking about using Reboa for hemorrhage control is, again, this open conversation and discussion about, okay, well, what else have we not thought of yet? And how long do we need to have it up? Where does it need to be? That kind of stuff. Luckily, this patient of ours, he had a small increase in his creatinine over the first few days after this, but really didn't have any untoward effects of the Reboa, and ended up, I think, saving his life. Embolization, always a hot topic too. And I think, there's old papers, and this is a relatively new paper, although relatively kind of low end, talking about the CT blush and how useful the CT with contrast, demonstrating a blush in the pelvis or elsewhere in the abdomen, can be used or not used. The problem with all the papers that I've reviewed, at least that have to do with embolization and complications, is that they're all relatively small cohorts and relatively, we'll just say low end kind of situations. The selective versus non-selective proposal in this paper, I think, is one of these things that's kind of obvious. I think if anybody who saw one specific problem anatomically that is solvable, that would solve the problem, would be happy to do that. But it's the patients that either have a lot of bleeding, or perhaps it's just a effort to kind of slow down the general bleeding, or even sometimes the venous bleeding by slowing some of the pelvic arterial flow. And the non-selective kind of situation, it's life-saving. And so I guess you don't complain about infections or complications down the road if you're not alive. But certainly the kind of thing where, again, the open communication is key, because the patient we have before is a pelvic ring injury, and a lot of these things can be treated percutaneously. We've got a paper, and lots of people have papers that with new advances, many of them kind of owed to Dr. Rout in terms of percutaneous pelvis fixation. Many of these pelvic ring injuries can be taken care of in a way that the complication rates, specifically in infection, are much, much lower, kind of closing in on zero. But if the patient has a combination acetabulum fracture, or is going to need an open approach for a pelvic ring injury, non-selective angio may be kind of a problem. And so, again, key to kind of have everybody on board before we make too many big decisions in these kind of cases. I think I've had one case that I can remember in 11 years, which is probably a good sign, although I've had a couple of humdingers that we worked on with other kind of perineal wounds, but I've only had one that I can remember getting diverted. I think the indications are things that I don't totally always understand. Of course, I imagine that if there's a perineal wound and it's going to be bathing in fecal material, that's a problem. But it also depends on how quickly and how expeditiously the debridements and the treatments are going to be taken care of. It also depends on the size of the wound. So the indications are sometimes unclear to me, but certainly kind of where the stoma comes out may affect, again, not so much any of these surgeries where we're doing things percutaneously. Sometimes it can be in the way, but sometimes it can be dealt with, and that's a collaborative effort too, But diverting patients to avoid infection is one of the tenets of the old look at pelvic ring injuries and unstable patients. And then the last thing, and we'll get a little bit back into this case, but there's two things to kind of think about when we're talking about fixing patients. Certainly uh, we kind of imagine putting skeletons back together and thinking about kind of long-term, you want your skeleton to be lined up the right way. You want to be able to walk normally. You want to be able to do things as close to your pre-injury state as you could. But even in the short term, I think most people think about external fixators as a kind of temporary way to be minimally invasive, reduce pelvic volume, stabilize patients, and provide a way that the resuscitation can be ongoing. You can keep the pelvis stable enough to form a clot, and they can live to fight another day and do other things. Mike Gardner used to be a partner of mine here, and he and Chip wrote up a paper where even iliosacral screws, if planned right and thought through, can be used as temporary, or if done really well in a temporary setting, kind of permanent fixation tactics. And if you think about fixation as more of a, clot encouraging and hemorrhage control kind of adjunct, these are pretty nice in the sense that they can get put in relatively small incisions, usually on the flank, don't usually succumb to infection, and they don't cause a lot of extra bleeding, but can provide much more stability than an external fixator, and certainly be a lot less problematic in terms of other management problems when the patient's wrapped up in a sheet or a binder. So even in the short term, fixation is key. And so this patient that we had, again, with his left hemipelvis kind of going cranially, got a traction pin after the X-lap was done and the Reboa is in. So we're working on a bit of a time crunch, but you can see that we've brought his pelvis back down to a more kind of normal alignment. It still has to be kind of close together. And so this kind of anti-shock iliosacral screw goes in. The incision for this drill is only about 1 centimeter, and then we can use the partially threaded screws to bring the pelvis back together. And so that plus this external fixator, because they had kind of a contaminated area around the anterior pelvis, basically has his pelvis nearly anatomically aligned. The CT scan will tell the real story, but certainly in the sense that the volume is controlled and he's got a lot of stability. He can go to the ICU and he can get resuscitated, and we can expect that he's not going to have any ongoing slow bleeding, venous bleeding, that kind of stuff. No, for this patient's case, he didn't go to angio beforehand. And I don't recall, but I don't believe he ended up going to the angio suite afterwards either. I think he stabilized, the Reboa went down, he went to the ICU, and there wasn't any worry about an ongoing arterial bleed. But certainly something that can be, all these things can be worked around if he has to go to the angio suite for ongoing bleeding that would be arterial. So this is where he's at with his pelvic ring closed down to some degree, certainly not perfect, right? And so you see a little bit more of the accentuation of his opening on the screen's left, but on the patient's right side. And then you see this screw is in, and it's holding his left hemipelvis together with his spine, but certainly not kind of anatomically aligned. Maybe a problem down the road for healing, maybe a problem down the road for alignment, but those things are kind of hard to parcel out. But this is the kind of thing that he can be rescanned, he can be resuscitated, and when he's doing better, he can come back and we can talk about, okay, what are we going to do to try to make this guy better for the long haul, right? So now he's survived. Is he ready to kind of undergo more invasive surgery if he needs it? So certainly we could try again with some minimally invasive techniques and try to get this lined up a little better and fixed a little better, and then address the other side of his pelvis as well. He actually ended up having a flank incision, which he had to be kind of resuscitated and ready for. So he waited a couple of days, but certainly did well there. I put this slide in because I needed to remind everybody we don't operate on everything. Certainly pelvises like this that are in patients that are hemodynamically unstable are most of the time very unstable. But if the patient has a pelvic ring fracture, but has enough stability that they can protect themselves and begin weight bearing, mobilizing the patient after any kind of trauma is key. And so some of these do get treated non-operatively, but how do we know that they're unstable? There's a lot of orthopedic literature about trying to figure that out. And I'm not sure we totally know yet, but more people are using examinations under anesthesia to try to get a little more in-depth look at what's stable, what's not stable, because it's harder to know for sure on a static CT or a static set of x-rays than we thought. It helps to control their pain certainly as well. And I think that that's at the baseline of this is people that get their pelvises fixed relatively early seem to use less pain medication. The patients that are in the ICU seem to do a little bit better, and they probably is somewhat related to not only kind of the ongoing, pain, inflammation cascade, but also it's easier for everybody to kind of tolerate moving a patient around when you feel like you're not, jarring them or hurting something that's still unstable, right? And so plenty of papers out of Seattle. I think, can't remember where Einenghorst is from, but Heather Valier up in Cleveland at Metro Health kind of looked at these things, and there seem to be a lot of good results when the patients have their pelvises fixed within 24 hours. It seems to expedite their care and certainly get them out of the cascade a little earlier. So really, we're talking about in the short term, closing the pelvic volume and providing a stable frame to help with hemorrhage control. It's just hard to move a patient in bed if they're not stable. They're painful. They don't want to be moved, and that hurts their skin and their lungs. It hurts their other injuries as well in the musculoskeletal system. When you're hurting that much, it's hard to breathe deep and it's hard to get upright. Both of those will help your pulmonary outcomes and hopefully help your GI tract get back to normal. In the long term, the outcomes are probably better. It's hard to kind of figure that out because some of these injuries are pretty severe and come along with nerve injuries or other pretty severe injuries. So, you get the classic research mixed bag, and it's hard to absolutely ferret out who did well and who did poorly. But it just makes sense that if you have an unstable pelvis or a pelvis that doesn't heal and stays unstable, it's got to hurt and it can't help you do better. People have been looking at this again for, 20, 30 years. And just to summarize it for you, I think probably point 3 is the biggest one. A lot of these injuries, their long-term outcomes are closely related to any neurologic injury they've sustained. So that makes a lot of sense. People will get better for about 18 months, maybe a little bit longer. Some of these studies are limited in terms of how long they followed people. There is the potential for a lot of people with pelvic ring injuries to get back to their previous job. Tile B and tile C is just that same idea we were talking about. If the entire hemipelvis is unstable, disconnected entirely as opposed to just disconnected from the front, makes a lot of sense. Those patients do better. Women seem to do worse than men in the world of pelvic ring injury, which I don't know of anybody that's come up with a theory for why, but that seems to be the case in terms of patient-reported outcomes down the road. Sexual dysfunction is prevalent. And again, in the multidisciplinary talk, this is something I've discussed. I've been lucky enough to talk with the urology guys too. A little bit of that long-term outcome that we don't really talk about. We don't really think about much. It's about survival in the short term, but a lot of patients have sexual dysfunction and don't want to talk about it unless you bring it up. And there are things that certainly can be treated if it's brought to the table. So I think that's certainly something to remember if you're seeing somebody down the road who seems to be still having trouble to think about. But I think certainly open reduction or closed reduction percutaneous fixation seems to improve outcomes in most of these. So again, getting back to our case, we ended up doing these retractors are in for a flank approach to his SI joint to try to line that up a little bit better. And we've kind of plated that to make sure we've got it together. And then you can see that we've got to fix the other side as well. It's got a little gap. So now we're squeezing both sides of his pelvis together and locking it up with an extra screw. Again, the flank incision to put the plate on and get the reduction is, probably a 10 or 12 centimeter incision over that crest. Certainly a place that you can bleed, but not the most bloody place in the pelvis. But the rest of these screws are placed percutaneously, so relatively low morbidity and low infection risk. And his external fixator stayed on. He came back only once 6 weeks later. His number one goal was to get the external fixator off, and that's all he really wanted. But you can see we've got his pelvis aligned quite a bit better and things locked up with a little more metal. This is him after his external fixator is off, and certainly a little imperfection in the front of his pelvis, but he was able to walk. He walked right out of clinic. He was just happy to have the external fixator off, which makes a lot of sense. So just to summarize things, I think that taking care of these patients that are hemodynamically unstable with unstable pelvic rings is all about, number one, having a systematic approach, having all the players involved in the planning, planning for things we don't know are going to happen. And then, being willing to be on the front lines and being willing to work together, right? I think that's a key part of these kind of injuries when we've got lots of people involved and everybody's got a priority, but we've got to make the priority the patient. Life-saving efforts can be undertaken while avoiding problems with other treatments down the road. And I think that's where this communication comes in a lot too. So, whether it's, even as simple as, the X-flap and going in for an umbilical Reboa use or not, embolization or not, these kind of things. And down the road to, calling the team back together and saying, my patient's complaining about sexual dysfunction. I mean, that kind of stuff is, this is a team effort from start to finish all the way. And all of these things have some interplay with each other. So communication early is the key. So as promised, this was going to be a relatively short talk. Dr. Knittel promised me that I could even almost put a title slide up. And if it was controversial enough, you guys would talk for an hour. So open for statements, questions, discussion.
Yeah, that's absolutely the goal. The more controversial, the better. And, it definitely leads to more discussion when people can express their opinions. There is a note in the chat already. I'll try and read it unless you're looking at it as well. So would you recommend pelvic binding in the trauma patient that arrives with a blast injury? And this is coming from one of our military folk. How would that play into the treatment? I think you're muted.
I was trying to make the thing come back down and the little drop come down to me. But yeah, so an excellent question. I think this is one of these things that it comes up a lot. When can the binder hurt? And it's to me, it seems like it's relatively rare, right? So there is, not to take us off track, but recognition of either the open book pelvis or the lateral compression injury. It's not reported that I've heard. And people may talk about experience where there are injuries that they think may have been caused by the binder being placed too tight, or in an injury where they kind of kinked the pelvis together. For the issue of open wounds, I think, and you actually, with your background, know this better than I do. Communication downstream is key, right? And so, the times I've seen it problematic are when open wounds don't get communicated. And so they're wrapped up and they're left wrapped up. But yeah, I guess, trying to understand the question exactly, you're right. Direct pressure, external or internal, is key. And then the question is, okay, if you've got a binder that's a prefabricated binder and you can't get access through it to get, groin access, I think if that's what you're getting at, can be problematic. Some of the prefabricated binders are wide enough as well that if you need, you can cut a hole in them as well. It makes it a little bit harder to kind of move the flaps of cloth out of the way. But if you're having ongoing hemorrhage that's external, then you're right. I think it's a nice way of becoming a potential adjunct to whatever packing you're placing in, right? The problem is it has to keep coming on and off. And then I think a little bit of your question too is there are people that, we've gone, from one end of the spectrum to the other where, now the EMS guys know if they have a suspicion for pelvic ring injury, they're putting a binder on, right? And so if that complicates treatment of other problems, that is a complication. And then, being willing to loosen the binder to treat those other problems, it takes some close monitoring, right? But these can be reapplied if, they can be loosened and reapplied. It's about monitoring. And it's actually pretty common around here to kind of, go around and either check the patients in the ICU while they're being monitored or check patients before we start in the operating room. Okay, the binder's on, we've moved the patient, we've got them most of the way positioned, but the last thing to do is, look at the monitor now and then loosen the binder and check it after the binder's loosened and make sure we're not having a catastrophic problem and we need to change course. I don't know if that answered your question, but I think, I see it as a potential adjunct for external wounds for sure.
Yeah, I think this is thank you for the talk, because I think this is definitely a topic where, when you talk about multidisciplinary approach, this in my mind is like quintessential for trauma, because so many services can definitely be involved. And I think you're exactly right. The communication especially has to be very clear. Um, when a lot of us are seeing the patient in the ER ahead of time and probably before you're aware of the patient, is there stuff that's important for you guys to know? Is there good preparation that we can do besides wrapping the pelvis? You talked about the lines and the reboa, and I know we're putting femoral lines in and things like that. Does anything like that interfere with what you need? Is there anything we can do that's going to hold you back besides not directly addressing the pelvis?
Yeah, I mean, I think that's an excellent question too. Is like, what have we run into that is like, oh man, this is like the worst location, right? I think that, I mean, the good thing about groin lines is, because of what they're going into, orthopedic surgeons generally try to stay away from that area, right? So most approaches that people are going to use are going to stay away from the line itself. The problem is if the skin incision or the approach, kind of crosses that area, right? For most of these pelvic ring injuries, like we were saying, there's relatively mobile windows or smaller windows a little bit off to one side of the groin. And so most groin lines aren't bad. Yeah, the issue is, when you're in the heat of the moment and you need a line, if it happens to be on the side that's kind of worse affected or going to be close to an X-fix pin or things like that, it's definitely helpful to kind of have some communication there, because those things will actually move quite a bit sometimes, or maybe even the place that if it's one side or the other, or if it's a choice between groin or somewhere else, it may just be harder to technically get a line started if that's the side that's unstable, and somebody can let you know, right? But I think that, again, kind of going back to, Chip and my mentorship, this is also one of those things that just takes, instead of kind of, throwing things on the ground and having a tantrum and saying, well, I have to do orthopedic surgery and everything's in my way. It's, getting creative and kind of working with people and knowing what's needed and what's not needed. And he was the first to kind of dress things up and cover things in IABAN and prep over things, and, show you how to move lines different places, and kind of, if it's oriented this way or that way, these things can be dealt with. And so I can't think of too many that are big problems. I think, in terms of what else to do, it's I think the times where we've had trouble, and this is going to be like probably more logistics than some of the guys on the call want to hear, but some of the guys really want to hear this probably. So the way our call schedule works is there are a number of orthopedic faculty that are in the call pool, but in accordance with the American College of Surgeons Level 1 status, there's always a traumatologist on backup. And I think that it should be okay for everybody to escalate this to the traumatology expert on backup. I mean, these are thankfully rare, but they are the reason why I'm here. And I think that I hesitate a little bit to speak for my partners, but I'm pretty sure I got 4 partners that would say exactly the same thing, right? So there's always somebody on the call schedule that is going to inherit this, that knows quite a bit about these things. And sometimes, it's just kind of getting the resident to shuffle a little faster on the kind of consult side. But, I think an open conversation is where these things start. I think the other last big thing would be, there are pretty big differences, but even some of the junior residents, as the year goes on, will be able to tell you, like, this is pretty involved and is going to take kind of an open approach. And it's probably going to be one of these two things, either kind of in the inguinal area or around the back on the gluteus or the gluteal mass, and those are also kind of, those are probably the ones where, like, yeah, the groin lines are probably not great, or any other kind of intervention from the other subspecialists, right? if they're going to have a big open approach, the infection risk, if they're embolized, is kind of there, the lines in the way, and then having to get other lines is there. So those things are worth talking about too. Acetabulum fractures in combination with this, or acetabulum fractures that get kind of bumped up the chain because they're pretty high energy, can be kind of trouble. Can kind of be trouble if open approaches are boxed out by some of these things.
I know there was a follow-up question in the chat just about wide belts, and in kind of different options in terms of pelvic binding. Any comments on that?
Yeah, I think, let's see if I can maybe go back a little bit. I don't know if you guys can see this screen, but this is like a classic CV line generator, but somebody wrote a paper about the various kind of binders that were available and how to apply them and what kind of force they generated, And, these were the kind of three of the big ones at the time. This whole thing can be relatively simple. And, you see that the SAM is a relatively thin one. The issue with using something that's relatively narrow is that you want to find the spot that's going to be the most effective. And it's probably over the greater trochanters. So if you can feel them, if they still have one, or if the hip's in the right place, that's a really good spot to put a narrow belt around somebody who has an open book pelvis. Putting two or three things on, I think, again, if you're kind of spreading, you're kind of dispersing the forces a little bit, certainly can be helpful. I think anything, like I said, going back to the sheet, can be used, right? So if you have any laundry around, if there's anything that can be wrapped, that can be useful, right? Certainly people used to use the inflatable or deflatable, beanbag or mask trousers. These kind of things also got used. And then there have been papers about this too, even holding somebody's feet, if their hips are not broken, right? If their hips aren't dislocated, and you just take somebody's feet and turn them in and tape them together, you can actually get quite a bit of force generated to internally rotate the hemipelvis in a patient who has an open book pelvis injury. So that's a lot that gets used as an adjunct all the time too. So taking tape, again, you don't want to leave it on very long, but if you tape their feet together with their toes, kind of pointed together and crossing, and then tape just above their knees on their thighs and try to bring their thighs internally rotated and together a little bit, can also be useful. But yeah, anything, in a bind, anything can be used. And I think if you can find their greater trochanters, that's the place to put it.
Any other comments, questions?
Hey, Dr. McAndrew. My name is Nicole Messenger, one of EM attendings. Fantastic talk, and thank you for giving this. I did have a question, especially with this kind of being a new year, new faces in the emergency department, junior residents and such. Especially with it being early in the year, are you okay with us reaching out to you guys a bit more about, sometimes the more unstable patient who's not quite as declared as this one that you talked about, but, I remember a couple of years ago, we had a woman who was transferred with a pelvic fracture, and her pelvic binder got taken down. No one knew about that by one of the residents, and she ended up coding because she just continued to bleed into her pelvis. Sometimes, and the resident we talked to was like, well, it wasn't open book, injury, so I don't know why the binder was necessary, et cetera. There are sometimes these small little, Swiss cheese models, or, they want to put a pin in someone's lower extremity to help with the alignment of the pelvis, even though they're going to go to the OR in like an hour and stuff like that. And it's going to be procedural sedation. I kind of wanted to know if you're okay with us reaching out to you guys a bit more for, like you said, an open kind of communication to make sure that, again, that we're all on the same page and the best care for the patient. But also if there's anything that you could kind of tell us, from your point of view of with some of these modifications that we done in the emergency department, that could help us to understand a bit more if this is something that needs to happen in department or something that can kind of wait for the OR, something along those lines be great.
Yeah, excellent points. And yeah, I think the first thing that, if I knew who it was, or maybe I'll just have to send out an APB. But the idea of taking a binder off and just saying, well, it's this kind of pelvic ring injury, so the binder's not doing anything, that may or may not be right. If it was a lateral compression injury and their volume isn't expanding a ton. But certainly lots of people, especially older people, can, they have more fragile blood vessels and they have arterial injuries. And there may be something about having a, even more tightly bound container that's helping them, make a clot or not hemorrhage as much, right? I think the key there is just talking about it, right? And it sounds like it was a situation of swooping in, taking it off and saying, it's okay, I'm going to go get the traction pin set while you guys are realizing she's crumping. And if it had been communicated, hey, let's take this off and watch the vitals and see how this goes, and we can put it right back on. You don't even have to take it out from underneath them. That kind of thing is pretty key. So I think, the concept there is, again, just, more communication on the baseline, but certainly it is early in the year, right? And so we all recognize that. I think the chief residents do a pretty good job of trying to mitigate that to some degree and trying to be paying more attention to what's happening, and then also, spending more time down there in July than the chief residents will be in June. But definitely feel free to reach out to us. And, the way our call is set up as well, we're kind of all on the hook for the daytime calls anyway. So, the access line calls us during the day until about 5, and only after that do you occasionally get kind of a random member of the call pool who may or may not be in tune with what you need, but there's always somebody on backup. So feel free to reach out earlier for sure. Last thing, I guess, what procedures need to be done in the ER and what don't. It is kind of it's a moving target in a way, right? So sometimes these patients are going, from the ER to the OR. That's certainly the case. And sometimes they're going to the floor, which is kind of a black hole for us. And it's hard to get some of these procedures done. So certainly for pain control and kind of helping everybody be alert to the fact that the patient's got an injury on that side, traction pins are used a lot around here. And do they all have to be done in the ER? It's a much easier place to do than the floor. And I guess, without knowing exactly which one you're talking about, you're right. Sometimes the patients are coming straight up from the ER, and sometimes, unfortunately, they're getting stuck in the ER for a long time for any number of reasons. And it's almost like we kind of thought they were on the floor and they're still in the ER. And that's one of those kind of things that happens too. So, traction pins are useful and they do take, I think sedation is good. I think it helps a lot of people. I'm not sure, hopefully it doesn't have to be a full knockdown drag out every time. With some good use of local anesthetic and some Verbicaine, that can be helpful too, but you can't do that alone. You can't do that just by itself. So it's always going to be you guys involved in some higher level thing. But yeah, paying attention to things like, a patient who just happens to have a OR time in an hour for a femur, and then, using up resources down there, I think we can certainly, steer the ship that way and try to minimize how much that happens. And some of these guys are eager to do things, and, they're trying to get it done before they have to pass the patient off, but try to keep that under control. But yeah, definitely feel free to call early and often.
I know you had brought up some other issues such as whole blood resuscitation, things like that. And yeah, I think that is something that we talk about a lot. And definitely, I think we've moved as a group to more whole blood resuscitation and really trying to replace what's being lost rather than the individual component therapy. And definitely less of the crystalloid approach and things like that. Any other, I'm trying to think of what else you brought up that definitely would be issues to talk about. Reboa is one that, unfortunately, Dr. Fortuna has left us.
Right.
And so he was one of our gurus. I'm curious what our approach is going to be going forward, because I know there's definitely differing opinions on that. This is the case that I always think of Reboa. If one's going to be really useful, this is it. I don't know if anyone, I didn't see a ton of surgeons on the list, but I don't know if anyone from the surgery side has an opinion on that, or wants to weigh in, or if anyone else has any comments, questions.
Well, I mean, I'll feel free to kind of open it up. You know, it's one of these things where, I mean, the numbers always look pretty horrible, right? When you look at some of these guys that have a lot of experience with it, they're talking about a lot of the worst, and so their mortality is going to be very high. There was it seems like a rush for a while at you know, this is all a little bit of conjecture and rumor and hanging around at some specialty societies and people talking, right? But it seemed like Ribot was very popular for a while. And then suddenly the survival rates, being the ultimate measure, were much better, right? And that was kind of, you know, questioned in the back hallway, right? And so I don't know. The technology, the theory, it's amazing, right? I mean, it's and you know, going back to the idea about blast injuries, I mean, there's a reason why this is where it came from, right? I mean, these are uncontrollable problems, and this is you know, is a huge technological advance for survival. But yeah, I think it's got more chapters to write, at least based on kind of what I've read, because I mean, even in the COT, which seemed to be where a lot of the proponents were, the popularity has kind of waned a little bit. And I think people are a little more skeptical about it. But I think, like most things, it's probably a tool that is so useful for somebody who's on call tonight to know how to use, because when you need it, you need it.
Well, and I look at it from our approach and just saying, you know, how can we address this in the ED? How can we address this when we're first getting these patients? And, you know, in my mind, access is everything. And you don't burn too many bridges if you gain femoral access. You can actually keep that kind of open. And having, you know, a femoral A line, a femoral central line, there's a lot you can do if needed, you know, down the road. And, you know, having already accessed the vessel, getting a Ribot in if you need it is much easier than starting from scratch. So it's one of these, it's not a bad place to start, you know, and can lead you down many of these pathways. I know Jason Gillihan has a comment. With Fortuna, ended up on ECMO. And Jason's right, you know, talking about how Ribot played a role. You know, I think in the right hands with people who use it, I won't say aggressively, but have the experience to use it when it's appropriate, you know, it can make a difference. And in a case like this, and I actually remember this case that Jason did, you know, going on ECMO, even going on ECMO is easier if you have femoral access and already have that lined up. It's much easier to load those and do better. So you know, something just for everyone to keep in mind. I think, you know, if we're putting in access, it doesn't burn your bridge and may help you down the road.
For sure.
Any other comments, questions?
No, Justin, this is Marshall Burks here. Just to how are you? Piggyback on that. You know, we can deal with femoral lines, you know, when operating on pelvises and all this stuff too. I mean, they can be prepped in or prepped out or whatever. So I kind of agree. In these extreme situations, we can deal with these variables that would otherwise be somewhat annoying. So I don't have any major beef with that for sure.
Yeah, it sounds like it's something, I mean, what's nice to know, and especially when we see these patients in the ED, you know, with our ED colleagues, you know, it's good to know that there's not much we can do that's going to interfere with you guys. So we have a lot of liberty in terms of we can take care of the patient, and we're not going to limit you guys too much. But I think, you know, kind of your points, Chris, on which side do we put the line in, and there are things like that. You know, if we can maybe keep in mind, okay, if one side looks worse than the other, maybe we can go to the better looking side and put the line on that side, you know, and think little things like that may help just make your jobs a little bit easier. You know, I think that's part of why we're here discussing this is how are we going to work better as a team when you have these cases that, you know, some teams are going to see the patient first and you're going to get a crack maybe a little bit later. Some things that have to get taken care of first. Let's not hold each other up.
Yeah, definitely. I think that's, you know, just being a little bit dynamic is always helpful. But I mean, the best relationships I've seen across these kind of problems are the ones where people have been together for a long time and just learn to deal with it. And then also there's an element of, you know, those of us who are kind of still, you know, if you put that line in the groin that I'm going to operate on next week, I'm pretty sure you're going to change the line, right? I mean, it's, you know, it's like there's an element of ownership too that also helps these kind of relationships. So it's definitely key. There are occasions when it's like, yeah, it's right in the way, but these things can be dealt with, and friends can be made over it. Friends can be made over a femoral line.
I like it. Well, on that note, if there are no other comments or questions, thank you very much again for talking at this. This was wonderful and really great because it does involve so many teams. And then just again, as a reminder, there will be no conference next month. So I will see you guys hopefully all again in October. So thank you very much.
Thank you. Thanks for the invite. Take it easy.